on to the next speaker, Dr. Akash Jain, to speak on evaluating contact of IOL with PC with respect to haptic orientation and CTR implantation using IOCT.
Good afternoon, everyone. So, toric IOLs have changed the way we address astigmatism in pre-cataract patients. There's only one problem. They tend to rotate, and the maximum rotation that has been seen is within 1 hour post-surgery. So, that brings us to our research question. Can we reduce the early toric IOL rotation? So, here is an intra-op OCT scan where the first line that you see is the anterior face of IOL. The second line is a posterior face of the IOL, and the third line is a posterior capsule. What we intend to achieve is a better IOL contact with the posterior capsule, which should look something like this. So how do we achieve this? For this, we had two arms of this study. First, we tried to orient the haptic. We checked whether orientation of the haptic has any role in achieving a better contact. So we implanted the haptics we implanted the lens in a horizontal and a vertical position of the haptics. So with that aim, we studied 100 eyes in a prospective interventional study. These patients were selected with normal biometry and a non-complicated cataract patients. After the preoperative evaluation, during a clear corneal topical phacoemulsification surgery was done, once the lens was implanted, it was first placed horizontally. Intraoperative OCT scan was taken, something like this. After lens implantation, we aligned the lens horizontally with the haptics horizontally, and an intraoperative scan was captured. A screenshot was taken of the scan. Then the lens was rotated to have the haptics aligned more vertically, and the scan was captured again. That's the vertical orientation. So if we compare these two scans over here of the vertical and the horizontal orientation, you would notice that when the haptics were aligned vertically, the contact was much better. So we measured this distance of intraoperative OCT in terms of pixel density, and the difference was around 20 pixel density in both scans, the horizontal scan and the vertical scan of the intraoperative OCT. The second arm of the study was where we implanted a CTR in these eyes and checked whether this implantation was any better. With that aim, we studied the 100 sample size of 100, and a random selection of CTR size was taken of 11, 12, and 13. So the patient eyes, the inclusion exclusion criteria was similar to the previous arm. After the preoperative evaluation during surgery, the lens was implanted first. Intraoperative scan was taken. A CTR was implanted after that. When we implanted the CTR, you have to make sure that it does not entangle with the haptics of the IOL. So that one slight adjustment is what you see right now in this video. And the scan was taken again after the CTR implantation. On comparing these two scans, you would notice that the contact has improved after a CTR implantation. So what happens is the CTR stretches the back to increase contact between the posterior capsule and the IOL. And when we compare the results, maximum contact was achieved by 13 mm CTR size, but the contact was better with 11 mm as well. Yeah, so this is the first study which checks the placement of CTR and IOL orientation in the same eye. This was done using a real-time intraop OCT, and all surgeries and the scans were captured under physiological IOP of 20 mm Hg. If you notice, the irrigation cannula is kept inside the eye with the IOP set to 20 mm Hg to have a more comparable outcome between the two eyes and the two groups. So how does this guide us further? During this study, we noticed that if you notice a sudden deepening of anterior chamber, these eyes are more susceptible, more prone to a IOL rotation. So that is something that we noticed, and any studies which talk about toric IOL stability should exclude these particular eyes, as it can skew your data. Companies should, like one of the proposal is that companies should design toric IOLs which need to be placed vertically to have a better IOL contact, and try using CTR in toric patients. This will reduce this early post-operative rotation. To summarize, vertical orientation of IOL provides a better contact of IOL with the capsule, and CTR provides a better contact as well.
What was the refractive status of these patients? Were they comparable?
Yes,
Meaning
sir.
to
They
say-
were comparable in terms of refractive error and biometry. So we, in both groups, in both studies, in both groups, we took patients where the biometry was comparable. The normal range of axial length, white to white, was taken, and none of the extremes of myopia or hypermetropia were included in the patient to have
and
a
the
more
same lens
comparable
was
result.
used.
The same lens was used in all patients.
Was there an increase in incidence of negative dysphotopsia in these cases?
Uh,
Once you put it, yeah.
So
Because
all
the optic haptic junction also prevents some negative photodysphotopsia.
I agree, sir, but that would be one of the limitation to the study, as sir rightly put in the previous talk, that this was something that we did not ask our patients. Maybe we should have asked, we could have had a reliable result, but there was no active complaint. We did not have a patient who came on POD1 saying that I am having negative dysphotopsia. Maybe we could have asked.
Thank you.
Thank
Thank
you.
you so much.